Good afternoon, dear ladies and gentlemen. Thank you that you are here. My topic is a practical interpretation of the results of molecular clonality analysis by fragment analysis and NGS assay in daily practice. We know that molecular analysis of clonality is a crucial analysis for us as hematopathologists when other diagnostic modalities do not suffice to make the diagnosis of lymphoma. For the hematologist, it means a chemotherapy or radiotherapy decision, and for the patients, it means a lot of stress psychologically and also physically. So the assay needs to be done precisely and also be corrected, interpreted correctly. I do not want to talk about technical details, and also I don't talk about molecular base. I don't show here the curves. I just want to talk about what is very practical in daily diagnosis. We know all it's about the rearrangement of immunoglobulin and T cell receptor genes by selecting V, D, and J segment for each individual lymphocyte. And if we have polyclonal expansion of lymphocytes, then we would have rearranged gene fragments with different sequences, different base pair length. And if we have monoclonal expansion, then we would have significant dominance of one special rearrangement with its individual sequence and also base pair length. The available techniques, the first one was southern blotting, but it needed high amount of DNA and was not practical for daily diagnosis. So the next technique was quite good PCR-based capillary electrophoresis called fragment analysis, which got standardized by European Biomed 2 collaborative study in 2003, now known as Euroclonality group. And it was applicable in routine diagnosis with the IdentiClone kit from Invivoscribe, which we used in our lab for daily diagnosis. The technique is semi-quantitative, and actually it compares the frequency of rearranged amplicons based on their base pair length. And it has some important positive points. It's technically relatively simple to be applied, reasonably priced, and relatively high sensitivity for primary diagnosis, around about 2%, when the quality of DNA is good, and it's simple to interpret. And the disadvantages is that it's not sensitive enough to follow the MRD disease. It's also influenced by somatic hypermutation, because when the base pair changes during somatic hypermutation, you cannot follow and track a clone. And it's also some technical problems which couldn't be solved with the primary set design. There is a preferential amplification of products with different sequences with the same base pair length. So these are also pitfalls that we cannot solve. The next technique, the miracle in molecular pathology labs, NGS, came, and Invivoscribe made also the kits, LymphoTrack, very sensitive and very specific method, very good, sensitive enough to track MRD and diagnosis MRD. Also you can follow the specific sequences, and you don't have the pitfalls that we had with fragment analysis. But there are also some disadvantages. It is laborious, especially for small labs, for daily practice, and it's also, in comparison to fragment analysis, a little bit expensive. But no matter which technique you use, we just want to look for the dominance of an amplicon, which is representative of a rearranged gene. Whether we look with base pair length or with a sequence. And there are different types of pitfalls which presents themselves in different forms. And we want to go through these to see how these pre-analytical, analytical, and post-analytical pitfalls would look like. And I start with a presentation of how could be the life beautiful with everything works optimal. We have a polyclonal population. You see many different rearranged DNA applicants. They look each like a line here in different frameworks with fragment analysis and also with NGS analysis. You see many different sequences. Actually, here each line shows a VHG segment combination, and each color is representative of one sequence. So you see we have a lot of sequences. There is also always a preferential segment selection. And if we have a monoclonal population, we wish to have such a result with fragment analysis and with NGS analysis. But unfortunately, it's not the real life. So that's, for example, the case one. We get a sample from clinician and they make pressure. We need diagnosis. Please apply the clonality analysis. That's the result you see we have in all frameworks with fragment analysis, non-reproducible peaks. We apply all of the analysis duplicate. So you see that these peaks are not reproducible. So that's the reason that we know they are just pseudoclonal peaks. Here as well, here we have nothing. And also here for framework 3, I marked the area that will look for the product regarding the base pair. And we applied a fragment analysis. You see that you have a dominant peak here in framework 1, but when you look at the number of reads is for clonality analysis quite low. And then we look for framework 2, we have a sort of oligoclonal pattern. Again, the number of reads is low. We need a cutoff of 10,000 reads for each tube, actually, for each reaction. And for framework 3, there is one sequence which is dominant. We can see also the same VHJ segment combination for framework 2. It could be otherwise good enough, but still the number of reads is not enough. Now we want to see what's the reason for such a result. That's the sample that we got from the clinician. It's a needle biopsy. You see a lot of collagen bundles which are PCR inhibitor. You see few number of B cells and very small aggregates of suspected BCL6 B cells, BCL6 positive, and they are so dispersedly located that we cannot do efficient macro dissection to get more of these B cells in our DNA extraction. So this time we put pressure on clinician and we asked to do an excisional biopsy, and we told we need really a better diagnostic material. So they also did it. That's the excisional biopsy of the lymph node. You see complete destruction of the structure, and you see a high number of suspected BCL6 positive B cells, and that's the result of fragment analysis. So it's much easier to make the diagnosis here. Now, my second case for pre-analytical pitfall. Here I start with NGS analysis. Again, you see in framework 1 oligoclonal pattern, or you may also say it could be also a polyclonal pattern, but the number of reads is quite low. For framework 2, again, you have a dominant peak, but the number of reads is quite low. For framework 3, the same. It's okay, the number is 7,000, but it's still less than our cutoff. So it's to make diagnosis, we try now fragment analysis. That's the fragment analysis. We applied it only for framework 3. you see we have a reproducible peak. So we interpreted the result of all of these actually analysis as the presence of dominant clonal B cell. But if you want to see what's the reason, this is the specimen control size ladder. You see this is the sample number 6. The amount of DNA is quite good, and actually the size of the specimen was also large enough. But the quality of DNA is very suboptimal. Most of the DNA fragments are only 100 base pair long. So that's the reason that we apply actually DNA quality and quantity tests always for all of our samples before applying clonality analysis. It's against the recommendation of some references. They say first apply the investigation. If you cannot interpret the result, then come back and do the DNA quality and quantity test. But I really don't recommend it. It's waste of time and resources. So the message of these two examples was to avoid pre-analytical pitfalls. Choose the right sample, select the right area when macro or micro dissection is possible, and apply a DNA quality and quantity assay for all of your samples before that you apply the clonality analysis. There could be a question. When it's possible also with bad quality of DNA, detect the clone with framework tree. Why don't we apply only framework tree analysis? That's the reason. Quite frequently we have with clonal B cell populations, what you see here is confirmed with fragment analysis of framework 1 and 2. We have a polyclonal pattern for framework 3 because of somatic hypermutation, and it's quite frequent. This is a non-specific peak for 200 base pair length, which comes, here is smaller, here is larger, but comes frequently, and you will see always the same size in all of your samples, so it's known you won't make a wrong decision when you have this peak. And now I come to case number 3. I come now to example of analytical pitfalls. Here I had a sample large enough, good DNA quality, good DNA quantity, and also good amplification. You see we have quite a high number of reads, enough for clonality analysis. But here we have a small peak for framework 1. For framework 2, the dominant peak has another VHJ segment selection, and you have a sort of oligoclonal background. For framework 3 the same, and also for Ig kappa. So we are not sure, do we have a really dominant clone in an oligoclonal background or not? We apply now fragment analysis, and here we see that especially in framework 3 we have the really dominant peak. However, the smaller dominant peaks are also present. And when we apply Ig kappa, then we have the answer. We have a quite significantly dominant peak for tube B. Why don't I talk about this peak in tube A? I come later to this phenomenon. The reason, you have for Ig kappa tube A, by actually more than 90% of cases, always these two peaks for 150 and 200 base pair, or 146, 196 NT. And that's not a non-specific peak. It's really a specific peak, but it's representative of many different sequences which produce all amplicons with this base pair length. So we need always to apply complementary heteroduplex electrophoresis. And here in these two cases, I wanted to show you, look at the case 1 and look at the case 2. I come to heteroduplex electrophoresis of case 1. This is our monoclonal positive control. This is our polyclonal control. And you see that the duplicate heteroduplex analysis, electrophoresis for these two tubes are polyclonal. So that's a polyclonal pick. And this is the NGS analysis. It shows also a polyclonal result. And now it's the second case. You see the pick is even not so dominant like the first one, but here in heteroduplex electrophoresis you have the band. And here it is an NGS analysis that you see the dominant clone. But now you may question, why do we apply NGS? We can just apply fragment analysis and heteroduplex electrophoresis. Again, there is one answer. Heteroduplex electrophoresis has really a low sensitivity. And also we have frequently problems with non-reproducible bands that here we cannot answer. What's the reason? Is it true? Was it a clone that we didn't pick in the second tube? Or is this one true and that one was a pseudoclone? So it's tricky when you are not sure with fragment analysis and heteroduplex electrophoresis. I always recommend to apply NGS analysis. So the message, apply assay of different gene regions, and if necessary, more than one technique to get a reliable result. Now we come to the post-analytical pitfalls. That's very important always to interpret the results of molecular clonality analysis with the histological and clinical findings. A dominant clone could be representative of a clone which is has undetermined significance, like monoclonal B lymphocytosis or MGUS. Or it could be reactive in an autoimmune disease or in a viral infection. And you may have a small dominant pick who could be representative of a tumor population in a huge background of reactive cells, or it could be also just a small dominant reactive clone. So we come now in case 4, example of post-analytical pitfall. I got a bone marrow. I do the histology, cytology, and also molecular analysis by myself. So I got the call from the clinician. He wants to have clonality analysis of a bone marrow. You see, we have very clear-cut dominant clone in framework 1 and 2, mostly 1 in framework 3. You see a second pick here. Here is the histology. Mild increase number of B cells in the bone marrow, really mild, and a little bit more significant increased number of plasma cells in the bone marrow, but it's not enough to make the diagnosis of plasmacytoma. So I should now decide, is it a B-cell lymphoma with plasma cellular differentiation? I have done MYD88 mutation analysis, it was negative, and I thought I need now more clinical information about the case. These are the clinical lab data. Patient is 78-year-old. He has 730 per microliter B cells in blood. They have CLL type immunophenotype, no lymphadenopathy, no hepatosplenomegaly, no mucosal or skin lesion, no finding in favor of a lymphoma. He has also a monoclonal gammopathy with doubling of beta-2 microglobulin, but normal values for hemoglobin, calcium, renal function test, no histolytic lesion, so no findings otherwise which could speak for plasma cell myeloma. So now I look at my results in another way. So what we see is that the larger peak is representative of these plasma cells, which are representative of an MGUS. And the smaller peak is representative for these B cells, which actually is representative of the monoclonal B lymphocytosis. So we have a quite dominant peak, but it doesn't mean a neoplasm. So that was the diagnosis, and of course the clinician agreed with this diagnosis. It passed, also fits to the clinical data. Message: not every dominant peak or clone means a neoplasm. We come to a case 5 example of post-analytical pitfall again. This time I start with clinical data. We have a young patient with normochromic normocytic anemia, normal values for anemia-related markers. I didn't write everything now here. Mild leukopenia and thrombocytopenia. She has also a mild splenomegaly. She has also dominance of CD8 positive T cells in peripheral blood, and morphologically they also have eosinophilic granules in cytoplasm. But she has also a sort of autoimmune disease which is not well characterized. And they want to know what are these T cells. So we apply clonality analysis. Here I show only the T cell receptor gamma because I wanted to keep the story simple. You see we have many different peaks in tube A and B, a little bit like oligoclonal. So I couldn't decide. We know that oligoclonal CD8 positive T cells, especially these TLGL cells, are quite common in autoimmune diseases, patients with autoimmune diseases, and you should only follow them and don't take them very seriously. So I just asked for repeating sampling after a few months. So I got the second sample after 2 months. You see that the peaks in tube A are disappeared. We have one dominant peak in tube B, but it's not the larger one from previous time, but the smaller one, which is now significantly dominant. Okay, what could it mean? We still wait. The patient has autoimmune disease, so I say, wait, it's not so aggressive, so we can wait, and after 3 months, send us, please, a third material. That's the third peripheral blood sample analysis. You see, again, no more dominant peak in tube A, but the persistence of this peak representative of the clone in tube B. So the diagnosis this time, in combination with the clinical data and other lab data that we have, with at the end TLGL leukemia. And the message of this case is the persistence of a clone, especially in case of T cell expansions, is as much important as its dominance. So, but T cells, you should be really careful, because we have so many samples from patients who have B cell lymphomas or they have autoimmune diseases, and we have atypical B cells in lymph node. So we say, okay, we apply the test, we do clonality analysis, and we have dominant clones. But when we follow the patient, so the clinic stays stable and the clone disappears. There are many nice examples, but the time is limited, so I cannot continue. Now, I would like to thank Claudia Bevacqua and Sarah Mullenbein, my MTAs, who applied all the fragment analysis, and Invivoscribe, who applied all of the NGS analysis for us. And if there are questions, I'm pleased to answer.
How many of those results are correlated with your flow cytometry results?
We don't apply flow cytometry because it's, in our lab. It's a tradition in Germany that fluid material goes to hematologists, and we get the formalin fixed and paraffin embedded tissue. So it's not often that we apply flow cytometry.
I'm just wondering if the tumor burden. I'm just wondering if the tumor cell fraction is proportional to the height of monoclonal peak.
It's very relevant, of course. It's very relevant. You know, when you have a diffuse sheet of large cells for diffuse large B-cell lymphoma, you don't apply clonality analysis. You usually apply it when you have, for example, question about marginal zone lymphoma, or when you have just a small cluster of atypical cells, and we see really a direct correlation of the number of suspected cells and the dominance of the clone. Of course, when there is not high somatic hypermutation, because when you have many subclones with different base pair lengths, then you cannot say that they belong to each other with fragment analysis, because they would stay a little bit close to each other, but not one peak. And also when you do NGS analysis, the same, because the sequences have a little bit difference from, depends how many nucleotides. So if you don't have too much somatic hypermutation, then it correlates quite well. And that's the reason that when it's possible, you do the microdissection. But in many cases, like marginal zone lymphomas, you have always the lymphoma cells mixed in the reactive background. You cannot do it.
Any other questions?
Since you are doing NGS, do you care only about the size distribution or clonality, or do you also analyze actual sequences?
Actually, we do at the first line always the fragment analysis. And when the fragment analysis cannot help, then we send a sample to Invivoscribe for NGS analysis. So for our first step is fragment analysis, but the reason is only economy, because the type of health insurance is in Germany for patients who are publicly insured doesn't allow us to apply NGS for all of the cases. Otherwise, we would do it really.
Yeah, actually, my question is: do you do the actual, ACGT kind of analysis?
We have the sequences. We keep the sequences because we can also do minimal residual disease assessment. So we do care about the sequence and not just the peak or something you see that is clonal. So it's very important, of course. Yes, we do consider the actual sequence that you obtain.
Okay, thank you.
Have you had any experience on doing the NGS clonality assay on a match sample, let's say from a lymph node and a bone marrow from the same patient? I'm curious to know whether the clonotypes match, the clonotypic profiles match.
No, I don't have.
Okay.